We've got the man and the legend, Professor Stephen Gilbert, giving us a hot take. Stephen, tell us your hot take.
So, perhaps everybody is going to be disappointed with anything I say after the introduction. A hot take on global health and the use of AI and the intersection of the regulation. AI in health actually challenges a lot of our pre-thoughts about how we regulate healthcare technologies. If I was asking you a question, is AI a medical device?
Well, it depends.
Yeah.
Depends on what they use
A
and the
lot
risk.
of my work is actually looking to challenge the paradigm of actually whether AI really is a medical device.
Go on.
Regulate AI as a medical device. If we ask the question, is it really a device? What sets out what a device is? A device is a tool created by human hands to carry out a task. What happens if the tool we create isn't for a specific narrow task, but can take on many tasks? And what happens if that tool interacts on a very, very intimate level with other human tools? Is it still a device? Are they devices? I'm actually not talking about agentic systems. I'm talking about non-agentic systems. I'm talking about the AI models that we implement within our healthcare systems, be they healthcare systems in Europe, in the US, or in Africa, are AI models that we get to interact with the electronic health record to give us advice on therapy planning for patients, on differential diagnosis for patients, on working with patients within the workflows. Those don't have to be agentic in the sense of autonomous, interacting with each other in a fully autonomous manner, but just in the way that they interact with each other on data. The way that we need to consider their local calibration when we train this model based on massive data and we locally calibrate it in the healthcare system, the way we need to consider drift in input drift, concept drift, domain drift, and we need to look at models in feedback loops to ensure that they work within local systems with respect to local workflows and with respect to the human in, on, and above the loop and on the other AI systems. We end up with a system which is very, very badly described as a device. If you consider it from an atomized level, we're going to regulate it as atomized devices. You end up as a regulator always talking a different language than the technologies that you're regulating, which are deeply involved with the patient lives and with the doctor's professional role and the flow of data in the health system, between the health system and the wellness space of the patient. We cannot regulate that space by considering it as a device. Now, my regulatory colleagues, when I tell them that, look at as if I've got two
They say,
heads.
oh my God, Stephen, that is a hot take.
That's a hot take. If I meet people coming from the AI world and I tell them what they're doing as a device, they also sometimes would look at me as if we have two heads. The really interesting space is not the observation, but the work that follows the observation. How do you get the current systems of medical device regulation and the current processes of regulators and our current oversight processes and some of the out there ideas coming from new technologies and get them to actually work together through stepwise incremental improvement is a very, very interesting space. And some interesting ideas are coming up, and I could list those.
Is the direction that you're going saying that therefore systems need to be regulated, or are you more saying it's therefore unregulatable?
I'm not saying it's unregulatable. It's hard to regulate. There is a train of academic thought, which is we should regulate AI as a doctor.
Yeah.
We treat it as if it's a medical student who has gone up through medical school. It's got certain skills, certain abilities, certain limitations, and you treat it like it's human. Personally, I oppose this strategy entirely.
Why?
Because in the end, the AI has not gone to medical school. It has not spent all the years you spent attending Imperial.
It's all right,
The
forgive me.
late nights in the library, the stress over passing the exams, the dependence of your family if you run up against the General Medical Council and lose your license to practice. AI models can, by their nature, be respawned. The situation where the AI is found to be not performing as well as it was, you can instantly have that model reappearing, recreated by another company. A company goes bankrupt, passes their IP on to another company, it respawns. They do not have skin in the game. Trying to simulate an AI model having skin in the game, you pretend you have skin in the game, it does not have skin in the game.
But then
I do not think the approach makes any sense, or at least not in the next 25 years of regulation. So my answer is we should not take that approach. That would be an ultra-radical approach.
Okay.
We do need radical approaches, but not that radical. And many people are proposing that. Eric Topol has written quite a lot of papers about that. Others within the regulatory community have taken that approach.
You've really well outlined the differences and therefore where the limitations are and where this analogy goes. I guess like when I hear that narrative, you take some of the principles of that, still recognize that it's different, but apply the principles that apply here. For example, the equivalence or reliance is if I go and practice in another country, I still have to go through some like quality or like updating in my own knowledge and some supervision before I'm like allowed to practice autonomously in another country. So it's like metaphorically taking it rather than literally. So then would that make it more acceptable to you, or you still think it's like...
The less strict you take it as a simile and the more you take it as a metaphor, the more useful it's going to be. You need to bring it a little bit closer to reality of the use of technologies close to the use case. As I have interacted quite a lot with the Tempo program, and those that designed formally from within the regulators on the Tempo program, and there's certain ideas that I published which have fed into parts of the thinking in that program. That's a program, if you're not familiar with it, which takes like a voluntary alternative pathway, not enforcement discretion in its traditional sense, as in the US market where we say certain areas aren't regulated, but enforcement discretion linked to flexible oversight of technologies, which is a negotiation and interaction between the regulator, aspects of the healthcare system, and the oversight of the healthcare system, and the manufacturer developer of AI models in between, in an area which is actually a quid pro quo over what is your new technology, which you are saying requires a different approach to enforcement, and the regulator saying this is what we need to see. So it's a form of sandbox. It kind of overlaps some ideas that are in the UK a lot. But it's slightly different to that, or it's very substantially different to that, because what it does is it links that not only pre-market, but actually post-market, and links it to outcomes. And one of the most clever aspects to that program, and an aspect that I had no connection with, is a linking up to what the healthcare system needs. That may seem strange in a country like America. Surely you start off from all enterprise is good, any new technology is good. It looks at it the other way around and says, there's all this promise. You attend a meeting like this saying we can transform your health systems, you can transform health through AI. What they actually do is say, well, this is how we need it transformed. We need transformation in aspects of patient management in chronic kidney disease. We need transformation in aspects of humans with metabolic disease and diabetes, with hypertension, with heart disease, with heart failure, and with mental health conditions and behavioral problems in age. And they say we want to see practical solutions that can help with the management of patients with these conditions. Come up with your proposals. We'll talk to you about the regulatory status of those with you. We'll even come in flexible solutions on oversight, but we will of course want to see data. We want to test outcomes, and we will test the outcomes, not like the German DEGA program where you will come and show us your outcomes. We will actually test the outcomes. And there's certain aspects of that where we need to be equally ambitious in Europe, equally ambitious in the UK, in terms of taking on aspects of that, which are, what do we want from these technologies? Not what are you offering to provide? What do we need to have in the
working backwards from where it's intending to.
What we intend to get to, where the health system is going to pay for it, rather than.
I am now convinced. Kind of. I think that's really important. We're totally missing that. Steve, thank you for sharing your hot take. And if you haven't already, check out a study Steve has led around outcomes with Mum Connect, deploying Ada Health into WhatsApp for maternal health outcomes in South Africa for underserved communities.